So thank you so much for the welcome. I'm so excited to be presenting today and so excited to be presenting in this new format. So I will be, of course, talking about the subject that I'm very passionate about, combining mental health in taking care of patients with CF. And as was mentioned, I've been working with the CF team, with people with CF and their families for quite some years at this point, and I am the first director of psychiatric and psychological services at our adult Stanford CF program, which has been just an incredible experience for me personally. So just a little bit about psychiatry in CF. Why psychiatry? So as a psychiatrist, I often get asked this question, not only from patients, but also from even professionals, other physicians. What is the difference between psychiatry and psychology? Psychiatry is a branch of medicine focused on the diagnosis and treatment of mental, emotional, and behavioral disorders. So psychiatrists are medical doctors who go to medical school along with future internal medicine doctors, pulmonologists, surgeons. And then after the medical school, they specialize in residency on treatment of mental health disorders, including substance use disorders. And they qualify to assess both mental and physical aspects of psychological problems. So psychiatrists provide evaluations and they treat with, first of all, identifying physical contributors to the psychological symptoms. And that's a very important part because psychological disorders can present with physical symptoms, but also physical disorders can present with psychological symptoms. So for example, a number of years ago, CF team referred to me a patient with CF for anxiety and insomnia. And I saw this woman in my clinic, psychiatry clinic at that point, separately from CF team. And it actually, for the evaluation, patient struggled with restless leg syndromes. And this is what was making her really feeling anxious, as well as had her struggle with her sleep at nighttime. And it was associated with iron deficiency. So after we replenished her iron, patients, this uncomfortable sensation of crawlies in her legs, which made her feel like she had to get up and move at nighttime. So that sensation went away, and also went away her anxiety and insomnia. So really identifying sometimes those physical contributors was really important. Or, for example, depression can present from somebody who has hyperthyroidism, or somebody can feel really anxious when they're on a high dose of steroids. So really disentangling those physical and psychological contributors is super important. And sometimes they coexist, right? Somebody with CF exacerbation and somebody with depression, and of course this can be and are comorbid, can present with fatigue. So psychiatrists are the medical specialists who are able to really sort of dissect that out. And then when psychiatrists diagnose the problem, they can treat with medications and or psychotherapy. Also, often psychiatrists who work with individuals with CF, they actually have additional training after their residency in psychiatry. They have training in what's called psychosomatic medicine fellowship or consult liaison psychiatry. And that's an additional year where they really work on kind of honing their skills, right, and helping patients with chronic and acute medical conditions. And there are a variety of ways how psychiatrists and CF teams can work together. They can be completely separate. So a CF team might refer somebody to psychiatry in a department, in the department of psychiatry in the same medical center or in the community, but really not know who that psychiatry is, and that's okay, that often happens. Or they can have a working relationship with a psychiatrist and refer patients to a psychiatrist, but not really share the same space. Or I'm biased, but being embedded in CF clinic, that's happening more and more, but not yet the norm for psychiatrists, and that can be a very helpful collaboration. So what has happened at Stanford, so we've seen this progression of collaboration. When I initially joined the faculty at Stanford, I was consulting to the team. So we were separate. I was seeing all the patients in psychiatry clinic, and then the CF team also would consult me for some of the hospitalized patients. And that worked for some of the patients, but the problem is that insurance might be a barrier, right? So not everybody, unfortunately, the way mental health is treated is differently from the rest of the body. And so some patients who are able to see the CF team at one institution are unable to see the psychiatrist and psychiatry clinic at the same institution. So that was a barrier. when CF Foundation has come out with mental health grants, that was super helpful. So we applied and we were lucky to receive it. And then my position was supported by the grant for 3 years. And now it's fully supported by the hospital administrations at Stanford Hospital. So we, at this point, have this model where psychiatrist is embedded in the CF team, into the CF team, and is present for the clinic visits, and also is able to see patients inpatient. And now insurance is not a barrier, which is really nice in CF clinic. So why, again, why psychiatrists, right? We often, we collaborate with psychologists and social workers, kind of other mental health professionals, and love collaborating with them. And all of us have our sort of expertise in particular areas of taking care of mental and psychosocial health. But there are some particular skills that psychiatrists are really equipped to bring to the team. So we all know that, for example, depression and anxiety are really common generally. And it's even more common, 2 to 3 times more common in individuals living with CF. So of course I have to put in a TIDES study right here. But the TIDES study really elucidated this fact when patients, adolescent and adult patients, and the caregivers of adolescents were screened. It was found out that 10% of adolescents had increased depression, 19% of adults living with CF, 37% of mothers and 31% of fathers of adolescents living with CF have depressive symptoms. And anxiety is even greater, right? Elevated to even greater extent. Not surprisingly, almost half of mothers of adolescents living with CF report anxiety symptoms. And we know that psychological distress in CF is associated with decreased pulmonary function, increased hospitalizations, increased healthcare costs, decreased health-related quality of life. And also, untreated depression can be associated with shortened lifespan. So definitely they are uncomfortable, and they have an effect not only on emotional well-being, but on physical well-being as well. So we want to make sure that everybody has access to those resources. In terms of treatment of depression, CF Foundation does have some initial wonderful guidelines to treat depression and anxiety. And one of the first intervention, should be psychotherapy. So CF Foundation recommends evidence-based psychotherapy, such as cognitive behavioral psychotherapy. But there are also many other wonderful psychotherapies, for example, acceptance commitment therapy that we will be hearing about shortly, after this presentation. And then also first-line medications that are recommended, the particular selective serotonin reuptake inhibitors. These are antidepressants that are also helpful for anxiety. The recommended ones, the first choice, include fluoxetine, sertraline, citalopram, and escitalopram. Of course, psychiatrists can prescribe that, but also if this is really uncomplicated medication-wise case, maybe pulmonologist or in PNCF clinic or PCP can prescribe these medications. But what happens if an individual with CF, let's say, and depression or anxiety, does not respond to the first line or the first 2 lines, right, of SSRIs, or there are side effects, or there are other recommendations, other considerations. So this is when really working with psychiatrists might be especially helpful. For example, a different antidepressant medication, mirtazapine, that is also helpful for anxiety, can also help with appetite and weight. So if weight is a problem and somebody's struggling with depression and anxiety, we might recommend mirtazapine. It can also be helpful for nausea. Or another consideration might be, we'll talk about it a little bit later, there are certain antibiotics like linezolid that are also serotonergic. They have some serotonergic effect, just like SSRIs. And that combination can increase risk, for example, of serotonergic toxicity. So, mirtazapine might be safer in that case as well. That's really a concern. SSRIs can also lead to sexual side effects, which are reversible, but of course might be quite bothersome. So mirtazapine is one of the antidepressants that has fewer sexual side effects. Bupropion is another antidepressant, works very differently from SSRIs and from mirtazapine, not as helpful necessarily for anxiety, but it might be especially helpful for somebody who struggles with motivation, energy. Sometimes it's used as a 3rd line for treatment of ADHD, and it also has fewer sexual side effects. SNRIs, these are serotonin norepinephrine reuptake inhibitors. medications like duloxetine and venlafaxine. So we might consider them when somebody does not respond to SSRIs, but also when somebody has comorbid neuropathic pain. So for example, somebody has diabetes and has pain in relation to that, or somebody has pain from pleurisy, or just ongoing chronic pain or migraines. So this is when we might consider SNRIs. And then of course, there are other medications such as aripiprazole, lamotrigine that we augment antidepressant treatment with. So of course, when we consider any of these steps, this is really when a team, a person and their family should be working with a psychiatrist. And this happens pretty frequently because, many patients will respond to the first SSRI, but many won't. So many patients will need to go on and try something else, try augmentation, or circumstances might change. And what if it's not, what we call just unipolar depression? Of course, unipolar depression, it has its significant burden. But there are depressions that come with other disorders, for example, bipolar disorder. And this is where it's important to diagnose that correctly. And we treat bipolar disorder very differently. So bipolar depression feels like just depression, but it comes in the context of a person having separate hypomanic or manic episodes. And when somebody also has manic episodes, they will be diagnosed with bipolar 1 disorder, and hypomanic episodes lead to diagnosis of bipolar 2 disorder. And symptoms of depression and mania or hypomania can also be mixed or coexist. So in general, bipolar disorder prevalence in the US is approximately 4%, and we don't have any actually studies of bipolar disorder in patients with CF. But it's important to know that bipolar disorder is treated very differently. We're not going to treat this with antidepressants, or at least not with what we call unopposed antidepressants. The primary treatment is treatment with mood stabilizers. So antipsychotics, quetiapine, olanzapine, lorazepam, and then, for example, anticonvulsants such as lamotrigine. So it's really, at this point, of course, it's very important that a person, is being treated and followed by the psychiatrist. Just to remind you, to educate those of you who wonder, well, what is hypomania or mania? So hypomania, which we see in bipolar 2, and mania, which we see in bipolar 1, and mania lasts longer and is more severe, of course, as the name suggests, are characterized by persistently elevated, expansive, this euphoric mood, or a really irritable mood with significant increase in energy. People have decreased need for sleep, but different from depression when somebody struggles with sleep, but also is very tired during the daytime. When somebody is hypomanic or manic, they actually are very energized, so this does not bother them. They might be really impulsive, spending a lot of money, gambling, using drugs, being more hypersexual than what is their baseline, making really impulsive decisions. They might be grandiose. There's sort of racing thoughts, pressure to talk. It's actually really hard to, almost impossible to interrupt somebody in conversation with somebody who has mania. And in mania, people can have psychotic symptoms. But hypomania can actually feel pretty good, right? You're super productive, you don't sleep much, you feel great about yourself. So when looking back, if we ask patients symptoms about the hypomania, often they might not even remember them because it just seems like a very productive part of their life. So there are some other red flags that psychiatrists can screen for when evaluating somebody for bipolar disorder. Early onset of depression, comorbid ADHD and depression, a depression that really does not respond to SSRIs, psychotic symptoms during the depressive episode, postpartum depression, which is depression after pregnancy, and depression marked by such symptoms as hypersomnia, which is sleeping too much, and hyperphagia, which is sort of eating too much. And these symptoms by themselves do not mean that, okay, if you have those symptoms that you have bipolar disorder, but it's just some of the other factors that psychiatrists might screen for. No studies of bipolar disorder in CF, has to be treated by a psychiatric provider. And now we're really using different medications. So it's really important to check for drug-drug interactions. Something that is actually studied more now in CF and is more prevalent is attention deficit hyperactivity disorder. It is a childhood onset neurodevelopmental disorder. Prevalence in general population ranges from 1.4 to 7.2% in children. And in general population, it decreases with age. Male to female ratio is 3 to 4 to 1 males to 1 female. And it's characterized by inattention, so somebody making careless mistakes, has difficulty sustaining attention on tasks, has trouble organizing activities, gets easily distracted, is forgetful, and or hyperactivity. So fidgety, difficulty waiting for a turn. So of course you can imagine when you have already a really robust treatment regimen, when you also have ADHD, it makes it even more difficult to take medications, to adhere to complex routine. Onset, according to the Psychiatric Bible, DSM-5, is before age 12. So the symptoms should appear before age 12. So this is again for general population. And symptoms, especially when the formal diagnosis is made, it's ensured that there are symptoms across several settings, home and school, right? School and work, so not just in one setting. In ADHD, in CF, we do have now emerging studies, which is interesting. And it seems that rates of ADHD in people with CF are actually increased. For example, a 4-site, multi-site study from Israel and Spain of 175 patients indicated that 18% of people had presented with symptoms of ADHD. So at least 2 to 3 times as high of prevalence, which I think is fascinating. Another interesting fact is that 16% of ADHD symptoms, 16% of younger population had ADHD symptoms, but even greater amount of people who are adults had ADHD symptoms. And again, we see that in other studies, right, in the US and Turkish studies as well, there's also smaller studies, but we also see elevated symptoms. So it's interesting that the incidence, even though again, smaller studies, but the incidence, the prevalence of ADHD in people with CF does not go down with age. It does not seem to yet correlate with FEV1 or BMI, but there are small samples. It does seem not conclude, there is not clear conclusions yet, smaller studies, but it does seem like it can negatively affect adherence, which is probably not surprising. And why do we see higher rates of ADHD, at least from the smaller studies in CF? Definitely we need more studies, but there are some speculations, is it genetic predisposition? We know that CFTR gene is expressed in neurons. We don't know exactly what it does. There's obviously chronic life stressors that can sometimes really trigger, right? Somebody is genetically predisposed, and then you have life stressors on top of it. So that can definitely predispose expression of any psychological disorder. And then chronic inflammation, right? We heard a little bit about, a lot about inflammation in prior session, but it's interesting that inflammation is actually one of the pathophysiological mechanism, along with others, of development of mental health disorders as well, and ADHD. So there's a question is it sort of this exposure of the brain to inflammation that also causes high incidence of ADHD? So many questions. How do we diagnose ADHD? So, there's actually a formal diagnostic procedure that needs to be followed for formal diagnosis. So that likely won't happen in CF clinic, no matter how amazing a psychiatrist is. But there are definitely scales that can be used, that we can administer and can pick up somebody who definitely there's a high likelihood of person having ADHD. So this is, for example, a scale that I use in clinic to check in with patients if that's a concern, and also has been used in some of the studies that I cited. And then, it will be treated with behavioral interventions, which are very important, but also stimulants. And definitely once we get to stimulants, I'm sure no pulmonologist will be comfortable prescribing that. There might be concern of weight loss with stimulants. So we need to determine, the effectiveness and the benefit of stimulant in case-by-case basis. But if it can help with adherence and quality of life, and in somebody who really struggles with ADHD, probably the benefit would outweigh the risk. Some other questions that come up for a psychiatrist who's working closely in CF clinic: we're starting Trikafta, any interactions with psychiatric medications? We're starting glymazelate, any concerns about combining with antidepressants? We're starting azithromycin, should we be concerned about QTC? A question from a patient: I'm pregnant, should I be worried about my psych meds? So there are definitely, lots of questions to answer. And I'm obviously concentrating more on the medication aspect of what the psychiatrist does. But again, I want to remind you that most psychiatrists who practice, who work closely with people with CF, would definitely also be skilled in psychotherapy as well. So the first question, right, CFTR modulators and mental health. First of all, it has been so exciting to be present and embedded in CF clinic during this amazing age of CFTR modulators and have conversations with patients, of course, those who qualify, especially for Trikafta, and do better and feel better and see how their psychological as well as physical health positively is affected by this. Seeing patients no longer qualifying for lung transplant evaluation, very, very exciting. But it's also important to note that there might be other considerations. For example, there have been some reports of worsening mental health after starting CFTR modulators. There are some published case reports and also some anecdotal cases that are shared between the mental health providers. We've heard about cases of depression, anxiety, insomnia, even with Trikafta, cognitive side effect. So not sure exactly yet what to make of it. Is it unrelated? Is it again the effect of CFTR modulators on the brain? Is it the effect of other physiological changes in the body due to CFTR modulators and the effect that has on the brain? Is it the drug-drug interactions or psychological effects of potential life-altering medications, right? It's important to remember that even amazing good things in life, can be really, and usually are really stressful, right? Having a child or having a new job or buying a house, or right now having access to medication that can really improve quality of life and prolong life. But sometimes these positive events make people really pause and reevaluate where they are in life. And that can be actually pretty stressful too. So that definitely comes up with some of the patients. But also there are considerations of drug-drug interactions even before starting CFTR modulators. And so, to remind most of you, right, our liver is the organ, one of the organs that metabolizes, breaks down the medications so that then our body can clear them. And there are particular proteins, enzymes in the liver, which CYP450 enzymes, that are some of the ways, not the only way, but one of the ways how our liver chews up and changes the medication so that they can be cleared by our body. And for example, and then, this is the whole family of CYP450s, and then there are members of that family, for example, CYP3A4. So I'm not gonna go into tremendous detail here, but knowing that, different, medications can either inhibit, sort of like speed up how these enzymes work. So then they clear the medications faster. So we might not have the same amount of the medication, which can be the case, for example, right, with Orkambi, because lumacaftor is part of it. Or they can, they can be more medications than desired because the metabolism is inhibited, or because now several medicines compete for the same metabolizing enzyme. But so it's important then to work with the psychiatrist and pharmacist to just make sure that, either you need to be monitored if you're taking psychotropic medication, or no change needs to be made, or a change does need to be made. Also want to bring up the fact that, for example, St. John's wort, right, an herb that can help with depression, but it's actually a significant 3A4 inducer and can decrease Trikafta effectiveness. So it's just important to know that just because it's an herb, right, it doesn't mean that it does not affect all other medications as well. Another question that comes up, linezolid, right, an antibiotic that has serotonergic activity and serotonergic toxicity. So pretty much, many antidepressants increase serotonin, and there are many other medications that increase serotonin as well. Stimulants, some opiates, for example, like tramadol, fentanyl, linezolid, right, an antibiotic. So we need to be very careful about how we combine these medications. And so the question, often is, for example, okay, so-and-so is taking sertraline, and we need to start linezolid. What are your thoughts on that? And the thoughts might be different based on the patient. Sometimes we might stop it. Sometimes if the depression is treated and the patient has done really well for some time, sometimes we need to decrease the dose. Sometimes we do nothing and observe. Sometimes we switch to something else like mirtazapine. But this is definitely a question for the psychiatrist. The psychiatrist and CF team will decide together, and the patient, of course. Other medications can prolong what we call QTC, right? And this is something that we measure on EKG, and it tells us how quickly the electrical signal is getting propagated through the heart. And prolonged QTC by itself is not dangerous, but it is correlated with dangerous arrhythmias, such as, for example, torsades points. So psychotropic medications, such as particular antidepressants, more classic antidepressants, such as tricyclics, but also novel antidepressants, in particular citalopram, and antipsychotics, but also many other medical medications, right? Such as azithromycin can prolong QTc. So again, when we combine those medicines, we need to be mindful about it and check QTc or think about what other risk factors an individual with CF who needs both of those has, and then make decision based on that. What about pregnancy and mental health in CF? What about, right, somebody who has CF, has depression, is treated with an antidepressant, and is planning or is now pregnant? And that's often a question really in any woman who has depression, anxiety, who's planning or going through pregnancy. There are always questions about the psychotropic medications, what effect they can have on a developing fetus, on mom, on a child, and because depression and anxiety, right, untreated depression and anxiety can negatively affect developing fetus and mom. Psychotropic medications also have their concerns. And this is a whole topic on its own. I want to just assure you, usually the answer is not to stop psychotropic medications. It's really important to treat depression and anxiety during pregnancy if they need to be treated with medications. But, medications might need to be changed. The doses might need to be changed. We need to think about how many psychotropic medications somebody has. And of course, this decision is even more complicated than somebody who has CF. But again, this is where definitely psychiatrists will be involved to help the patient and the team to make decisions. And then yet again, another area where psychiatrists, a CF psychiatrist, might be very helpful, transition to transplantation. So when somebody is evaluated for, I'm looking at my timer and have a few more minutes. When somebody is evaluated for transplantation, there is also psychosocial evaluation, which is a big part of the evaluation for transplant. And transplant social workers are involved in that on the transplant side, and often they're also transplant psychiatrists on the other side. So at Stanford, I also serve as a lung transplant psychiatrist to the transplant team. But often the CF psychiatrist who works with CF patients, they know what psychosocial evaluation entails, right? They can really help to prepare individuals with CF and their families for the evaluation and optimize all those factors that the transplant team will be looking at to really, with the goal to maximize the success of person who goes through transplantation. So that may be very helpful use of the psychiatrist embedded in the team. So, it definitely has been quite a journey for me personally to be working with the CF team, to be working with patients and their families, and it has been so meaningful and so rewarding. And I think the role of psychiatry will continue to be really needed and expanded with all the progress that we have, right, with CF care, with all the progress that we expect to have. There will need to be the need for ongoing management of emotional and mental health conditions as a part of a chronic medical condition. We definitely need more research into mental health and substance use disorders, which I've not mentioned in this presentation, in patients with CF, more studies on depression and anxiety, but also ADHD, bipolar disorder, substance use disorders, and medications, because there are actually no studies on use of psychotropic medications in patients with CF. We need to be mindful of drug-drug interactions as new treatments come out. And then, it's also psychiatrists, as our colleagues in psychology and social work, really are experts and really can be very helpful allies in working through the stages, right, of transitioning peds to adult, pregnancy, parenting, transplantation, but also aging, right, and palliative care for some of the patients. So these are just some of the roles that I can envision in terms of, psychiatry, psychiatrists be very helpful allies to the individuals with CF, their families, and the teams. All right, so my last slide is sort of a plug, but also, myself with my amazing colleagues from MGH, Dr. Georgopoulos and Dr. Stern, and also multiple other contributors from around the country, as well as people with CF, have put together this guide, which is Facing Cystic Fibrosis. And I just wanted to, some of you might know about this, but I just really wanted to share that this guide is available, just so there's such an amazing information there for patients with CF and their families, really talking about psychological, a lot of tools and education about mental health aspects, and also physical health aspects of CF. So if you haven't checked it out, check out if it's something useful for you. And if you find it useful, let us know.